seminar series. And I'm very pleased to introduce today's speaker, Dr. Abigail uh, Batchelder, who is a clinical psychologist and researcher with a public health background. She is an associate professor in the Departments of Psychiatry and General Internal Medicine at Boston University School of Medicine with a secondary appointment in the Community Health Sciences Department at Boston University School of Public Health. She is the Associate Vice Chair of Psychology, as well as the Director and founder of the Behavioral Health Equity Program in the Department of Psychiatry at Boston Medical Center, the largest safety net hospital in the Northeast. She is also an affiliate investigator at the Fenway Institute, a federally qualified community health center in Boston. Dr. Batchelder has received 15 grants as PI or MPI and has been funded by NIH, SAMHSA, Harvard, UCSF, private foundations, and industry. Her work aims to collaboratively identify and adapt and implement evidence-based interventions with and for underserved people with unmet psychobehavioral needs. And I also want to say that, as noted, Dr. Batchelder was previously at UCSF. And so it's very nice to welcome you back. And thank you so much for joining us. So without further ado, please give Abby a warm welcome.
Thanks, Milo. I did my internship, my clinical psych internship at San Francisco General through UCSF, and then oh my gosh, Valerie Gruber is here. Oh,
Hi,
haven't
Valerie.
seen Valerie in years. Hi, Valerie.
Hi.
Oh,
I'm having IT install a printer, so
oh, it's so nice to see you. I'd love to catch up at some point.
yes, it would be fantastic.
Yeah, that would be so lovely. Yes, so I was just saying that I did do some of my training at UCSF, and it continues to hold a fond place in my heart, and I think informed a lot of the work that I'm still doing. So with that, thank you for that orientation and welcome, and thank you for inviting me, Milo. I'm going to share my screen and then share these slides. So I have two screens. Can you all see the intended presenter view? Okay, lovely. So Milo asked me to present, and I thought, since we have this opportunity, I think, to ask questions and to talk afterwards, I would present this in kind of a way that is top of mind for me as I think about intervening, like getting psychobehavioral intervention strategies to some of the most underserved people. And I work a lot with people who use drugs. So that's really, really important to me. And one way that I've been kind of moving towards doing that is thinking about how we can kind of flexibly parameterize what we know to be really effective, and to leverage the deep well of psychological knowledge that we have to meet communities that really haven't gotten access to that knowledge in a way that they could. So I'm going to kind of walk you through a trajectory of mine that is kind of moving in this direction. And then I'm really thrilled to have the opportunity to hear others' thoughts about some of these ideas as we think about what we can do to really reach towards behavioral health equity for people who could really benefit from it. So I'm not going to bore you with my affiliations. Mila went over that, but I am stationed in Boston at the biggest safety net hospital here. It's similar in many ways to the General, which I know is Zuckerberg General, but it was not called that when I was there. I never call it that. And really doing that type of work. Okay, so I'm going to give you a brief background on me, just to orient you all to my positionality and how I came to this work briefly, and then talk just a little bit about the kind of literature landscape view that informs the work I do. I'm not going to go into great detail there, but I'm happy to share more about that. And then I'm going to spend the bulk of the talk talking about my trajectory to think about meeting people where they're at, people who use drugs, living with HIV, and what we can do to think about collaboratively adapting what we know to be evidence-based to really meet people and be deliverable in a way that's accessible and meaningful and feasible and sustainable for people who use drugs. So I'm going to talk about the Matter intervention trajectory and then the iStrive intervention trajectory that are interrelated. So in brief, I'm a psychologist with a long-standing focus on health disparities and public health. So I got an MPH at Columbia in sociomedical science, knowing I wanted to go on to clinical psychology. And I really wanted to partner them and pair them and think about public health psychology for multiple reasons. I was very aware throughout my early life about how many people didn't have access to psychology and psychological treatments in the same way that others did. And I became very focused on that and very interested in thinking about, well, how can we expand that and help people get what we know to be effective and what might be really beneficial. So a lot of my work, my training started in New York, and I started working with people with HIV around 2007 in Northern Manhattan and then the Bronx, where I did a lot of my training. And most of that work was in urban substance use and HIV clinical settings. Some of that was in San Francisco with Valerie and others. And a lot of my early work focused on people living with HIV and Hep C. I worked a lot with people who injected drugs and a lot with people with opioid use disorders and now stimulant use disorders and polysubstance use is more normative in my world. And throughout this work, I'm a mixed methods person. So I was doing qualitative work and quantitative work in these various settings. And then even in some of my clinical work, I started to hear a narrative that really came through pretty consistently among people with substance use disorders, with these other challenges. And that was, when they told me and they conveyed to me that when they felt bad about themselves, when they felt less than, we might say, which we might conceptualize as internalized stigma or even shame, they were less likely to show up. They didn't want to go to appointments. They didn't want to take their meds, and they wanted to use more. But when they were feeling better about themselves, maybe like higher social status or self-worth or less internalized stigma, they were more likely to engage in self-care behaviors. And there seemed to be a cascade effect that happened for many. And that was so compelling to me that I actually pivoted in grad school from focusing more on depression as a barrier to engagement in HIV care to thinking more about deconstructing and understanding what these almost like psychosocial barriers were that we might consider being like the ramifications of stigma and devaluation in society. And since then, I've expanded some of my work to focus on sexual and gender minority people overlapping with substance use disorders and aging with HIV, but I'm not really going to talk too much about that. I'm going to talk more about people who use drugs, including sexual and gender minority people. So really brief, there's a rich literature here, but we know that people with HIV are disproportionately experience psychobehavioral challenges. I can't imagine that's news to anyone on this call. We see higher rates of depression and PTSD, and we know those things can get in the way of HIV self-care, adherence, appointment attendance, et cetera. And we know that people with substance use disorders and HIV have a lot of unmet psychobehavioral needs and often have trouble accessing mental health services. And depending on how you look at this data, it can look different. But when you really dig in, it seems that the people with substance use disorders and HIV are not necessarily getting the care that they could benefit from. And I think that's an important qualification. And that's for a lot of different reasons. It can be difficult to access support in terms of like where they're located. Like here, we're looking at if someone can only access support in psychiatric settings, which are usually it's a department in the hospital, or maybe through a virtual setting versus somewhere that's more co-located with somewhere that they're already getting their subsistence needs met or their substance use disorder needs met. There's challenges with regard to duration of treatment. If I have to lock in for 12 sessions, can I really do that if I have an active SUD? Accessibility of content. Sometimes there can be cognitive barriers or challenges to really engaging in what can be really cerebral content, like cognitive restructuring, for example, or whatnot. And sometimes we see folks who really ebb and flow in terms of their ability to really get what we're putting down when it comes to psychobehavioral interventions or evidence-based psychobehavioral interventions, depending on where they're at in their use cycle or depending on where they're at in relation to other mental health challenges. And, I would say classically and pervasively, there can be a rigidity in delivery strategies. There's kind of an old belief that, you can't engage with people in terms of psychotherapy until they've dealt with their substance use disorder. And my thinking and some of my research questions really revolve around, well, sometimes it's really hard to work on that substance use disorder if there are concurrent mental health challenges that might be bidirectionally contributing to that, such that I think, and I hypothesize that there could be real benefits of intervening psychologically in a way that is accessible when someone is still in use or using. And I certainly come from a harm reduction standpoint, so recovery is not the only potential endpoint either, I would say. Additionally, psychobehavioral challenges can exist and do exist often that are not necessarily linked to a diagnosis. And this is something that I saw that impacted my trajectory also. Sometimes someone is presenting for substance use treatment or other medical care, HIV care, and they have a substance use disorder. And they meet for something like bipolar disorder or a major depressive disorder. And then, you can link them up to mental health care. But other times, it might be the psychological ramifications of the way society is treating someone, for example. So like the weight one carries for feeling very stigmatized for being a person who uses drugs, or a person living with HIV, or a person with other identities that might be devalued in society. And those psychobehavioral or psychological challenges can be very behaviorally influential, I would argue. And the evidence really indicates that. So what do we do then when we have kind of an insufficient mental health infrastructure for people with DSM diagnoses, let alone for someone who's grappling with other psychobehavioral challenges that are less easy to categorize and therefore bill for? So these are some of the things that kind of weighed heavy on my mind as I thought about my own career trajectory. And I found I kind of corroborated some of this messaging in the Bronx and in San Francisco and in Boston with people who were recently diagnosed with HIV, people living with Hep C, who inject drugs, et cetera. So we know that there are evidence-based psychological or psychobehavioral interventions with great impact, right? I think everyone on this call probably knows we have really good stuff out there. We know what can work for depression as a barrier to adherence, for example, and various other challenges to engagement in HIV care and optimization of HIV outcomes. But most of these interventions haven't been, I would say, collaboratively adapted. And when I say that, I mean really like working with people who have the barriers that we're seeking to really reach that might not be getting to those treatments, to ask like what is needed, what do we need to do differently, how do we need to move this or change it to make it useful to you, and we really haven't done that, I think, as systematically as we possibly could for some of those evidence-based or evidence-informed interventions. Additionally, people with substance use disorders living with HIV are a pretty heterogeneous group, I would say. And not only in kind of aggregate, but also within person, there can be real differences in terms of what people need at different times. I work a lot with people who use stimulants, and some weeks someone can be really attentive and really engaged with me in a psychotherapy visits, and other weeks, they might be coming off of using for a few days in a row and just don't have the same capacity to engage. So some flexibility, I think, in delivery and content and the way we conceptualize what it means to be delivering evidence-based intervention strategies need to be implemented. So thinking about that parameterization of flexibility is something that I've been spending a lot of time thinking about. So I'm going to take you through the trajectory of a psychobehavioral intervention that I've worked on over a decade now, that is now in the R01 stage. So I don't have like final efficacy or effectiveness data, but I think it kind of talks through this point. And I do have some pilot data that I'm going to share. So I wrote this, or just like thought about this while I was in California, actually. So I had done a lot of work in the Bronx at this point. I had done my training there. I was in San Francisco working with Valerie and others. And I started to kind of put it on paper. Like I was working with folks who were coming into my office often with multiple, what we might consider like experienced stigmas or like with reasons that they were discriminated against. HIV status, socioeconomic status, living with a substance use disorder, many of whom were sexual and gender minorities, many of whom were marginally housed or unhoused. And within that, they were living in a context of intersectional stigma and discrimination, inequitable access to social determinants of health, multiple barriers, structural barriers, and otherwise to health and mental health care. And for some folks, that was really becoming pretty internalized. Not everyone, but a lot of the people coming through my door would describe, this kind of weight and pressure and feeling bad about the self, or the oneself, this internalization, what we might say of the stigma. That's reductive, but that seemed to be happening. And that seemed to be associated with like self-conscious emotion, which is totally reasonable. That's how many of us feel. I mean, we all feel that way sometimes, but this idea that we just want to kind of pull the covers up over our heads and avoid the source of this negative emotion. So avoidance coping is sort of the natural sequelae of that for most humans. And so I started thinking about, okay, if this might be the path, what's happening for many people, it's completely understandable that one might then avoid the sources, the reminders of some of these sources of pain or negative emotion, like medication or taking drugs more to not be as present. So I did kind of a deep dive in what could mitigate that pathway. And I was lucky to get some funding for training in this area and thinking through this intervention strategy. It was actually, I think, a UCSF grant to think about, okay, like how could we intervene on this pathway to improve or to mitigate the negative consequences of these negative self-conscious emotions and internalized stigma. And I wanted to think about scalable strategies that weren't necessarily diagnostically linked. So that was really important to me too. So what could we produce that could be maybe brief enough or low enough person power to be implementable in like relatively low resource settings, or at least low resource from a mental health care capacity to address this particular kind of non-diagnostic barrier to self-care. So I got a series of grants. Oh, I wrote it here. Great. So the first one that really enabled this was the CAPS Early Investigator Pilot grant. Innovative Early Investigator Pilot Resource Allocation Grant that enabled me to do a series of qualitative interviews with people who worked with populations that might benefit from this intervention, as well as individuals themselves who might benefit from this intervention. And then I did a proof of concept study, which Adam Carrico supported me on. He was my primary mentor. And I think Jenny Jane, you were working with Adam at that time. So that was happening, that happened at the General. Valerie, I think, helped me find space at OBOT and at Alliance Health Project. And we got about 10 people. And I don't have the data here for that, but we basically developed the intervention. I'm going to tell you a little bit more about how we developed that. And then we did a proof of concept. Like, would people engage? Would they show up? Would they do the intervention? Around that time, I was asked to come to Boston, and I did, and I ended up being able to, everyone I was working with was awesome and really gracious and helped me finish that project after I came out east. But I ended up wondering, like, what's different in Boston? We were seeing some data in the exit interviews from that proof of concept work that there might be differences in sexual minority men versus some of the other individuals who we had interviewed and had gone through the pilot. So I got a mixed method study grant at through Harvard CFAR to assess internalized stigmas and shame in relation to avoidance coping, to look at that hypothesized mechanism of action, and then refine the intervention based on that qualitative data, which I'm also not presenting here, but it was over 200 self-report data from over 200 men living with HIV who used drugs, who identified as sexual minorities, and 30 qualitative interviews, maybe 32 or something, with the same population, but people who were suboptimally engaged in care. So we looked at that data, we informed the refinement of the intervention, and then I got a Early Career Development Award from NIDA out here in Boston to further refine the intervention for that particular population, and then do a pilot proof of concept, pilot trial, for which I do have some data that I'll share with you. And now we're at the R1 stage. So it's been this kind of iterative process, refining, getting feedback, better understanding what is needed, to really deliver this flexibly parameterized intervention strategy. During this time, during the K, we also had an outbreak of HIV in Boston among people who injected drugs. And I had the opportunity, to work with some of the Department of Public Health folks here. In fact, I think I'd emailed them shortly after landing, and the director of infectious disease there was very kind and met with me. And we talked about what was needed in Boston. And one of the things that they really thought was needed was an intervention to mitigate the negative consequences of stigma among people who inject drugs, because we were seeing these outbreaks. So I ended up writing an R34 during this period, to refine, to produce an intervention for that population, which I'm also going to tell you a little bit about, which really pushed the limits of flexibility. I have to say, we're in the final stages of recruitment now. So this intervention, in a nutshell, leverage some evidence-based content and evidence-informed content. I am not a purist in any way. I'm not a psychologist who feels like, oh, we have to take ACT or acceptance and commitment therapy and do it with everyone in the same way. A lot of these evidence-based interventions have, or evidence-informed practices have, overlapping content and quite, I think, straightforwardly be distilled into certain concepts that can then be combined in ways to really meet people where they're at. And that's very much what I have done over the course of my work. So this one particularly leveraged some of Adam Carrico's Artemis content, some of Steve Safran's Life Steps, which is kind of basic behavioral medicine strategies, and some other strategies like Kristen Neff and Chris Germer's Mindful Self-Compassion. And the details can be written up here. It can be seen here. I'm happy to share that paper with anyone, but that's kind of the way this intervention was made. And the synthesis, I think, is a real part of this idea of parameterized flexibility that I've been thinking about a lot lately, in that there are three core concepts in the MATTER intervention. It's delivered over 5 face-to-face sessions, and the intervention itself is intended to be implemented with this text messaging platform that is intended to extend the impact of the intervention at relatively low person power, making this like potentially more scalable. And various conversations I've had in Massachusetts with my Department of Public Health colleagues have been like, how could we design these interventions in such a way that they could be funded? And the whole funding landscape is obviously kind of in flux right now, but these interventions are very much designed to be implementable at relatively low cost for what they are. So it's only 5 sessions, which might sound like a lot depending on your background, but for clinical psychologists, that's pretty brief to work on really changing the way someone thinks about things. So the core concepts are on this one are metacognitive awareness, cognitive reframing or restructuring, and self-care goal setting. And they kind of braid together some of the evidence-based content out there. And they really kind of emerge from these qualitative interviews that I did to produce this intervention, and then the various studies I mentioned along the way to help refine what we thought was needed, and then what we identified as in the kind of cascade, if you will, of what might be happening, those identified mechanisms of action. So I'm happy to talk more about this if anyone is particularly interested, but in a nutshell, the metacognitive awareness is just a fancy way of saying like knowing what you're thinking and feeling. And so we text everyone every day, how are you feeling? How are you feeling about yourself? And there's a second part of the intervention for which we send them their written and selected statements back that's more akin to cognitive reframing, the second core tenet, if you will. But metacognitive awareness, we ask them how they're feeling. We do some informal mindfulness, helping them pause and think about how they're feeling and what they're thinking about. And this is kind of a basic component of most psychobehavioral intervention strategies. It's sometimes called different things, but there's power in pausing and thinking about how we're feeling and what we're thinking. And it can lead to questioning, like, Am I feeling sad, or should I be upset that someone was rude to me? Or maybe that was an unreasonable comment that that person made, and I'm actually going to be offended if I give myself that moment to pause and maybe not feel ashamed, but maybe feel irritated. Or like I need to leave this situation or protect myself or something like that. Cognitive reframing or restructuring in a nutshell is just being able to adjust the way we're thinking, which most psychotherapists will tell you is actually a really hard thing to do. So we hit on this idea every session. People come up with these compassionate self-statements, which often start out as like just positive self-talk, but become more complex usually over the course of the 5 weeks. And we infuse it with ideas and content about self-compassion, this kind of radical idea that we're all valuable and deserving of dignity and respect and taking care of ourselves. And then, as I mentioned, I'll show you the slide next about the bidirectional text messaging, but those are sent back to folks for 8 weeks. And then the self-care goal setting is kind of bread and butter behavioral medicine, like asking people to come up with a self-care goal, and then we iteratively refine it every week for 5 weeks. And we basically build what I would call like behavioral self-efficacy, this idea that we're all people who can accomplish our goals and sometimes need to scale them back, but we can build that skill set. And we've gotten a lot of good feedback that people like this component. So in terms of parameterizing the flexible delivery strategies, I want to just touch on this for a moment. So this is something that we're doing in the R01, but we also did it in the pilot, and we're doing it at iStrive too. But we have kind of 3 levels, if you will, given that we have these core tenets. And we're still working on analyzing this data, but I thought I would talk about it here because I'm curious what other people think when we have a chance to chat later. We have the fully scripted manual. So this is kind of following course, how people come up with intervention strategies. We have the fully scripted manual. It is stated explicitly that we are not to read the manual necessarily. We can be flexible with it. And to identify the parameters of that flexibility, I have checklists for every session, which hit on all the components of the session. Within those checklists, we have color coding of the 3 core tenets, such that a therapist could gauge in real time, is this a person who can really engage with me for the full hour to the max, in which case we're going to do something kind of paraphrasing the full manual, like the pages of content, the examples, all of the exercises that are intended, etc. Or is this someone who really can just go through and we can kind of touch on the ideas or the intentions? Or is this someone who is really having a hard time engaging with me, but I might just be able to hit on the 3 core tenets? If so, we ask the interventionist to simply try to do at least something from each of the color coding, such that they're getting behavioral, the 3 things. They're getting metacognitive awareness, cognitive reframing, and self-care goal setting in every visit. And it's designed as such. It's not an intervention that's truly modularized. For those who are familiar with kind of the current evidence-based intervention strategies out there, where there might be one session that's devoted to self-compassion and one session that's devoted to mindfulness. This is not that. This is more, let's try to hit people with the ideas as many times as we can, kind of pulling from learning theory to get people to build scaffolding kind of on these seeds we're planting, and then try to help people cultivate the knowledge base to use these ideas over time in an integrated way. And the text messaging is part of that. So we're conveying metacognitive awareness skills every day by asking them how they're thinking and how they're thinking about themselves, how they're feeling and how they're feeling about themselves. And then for 8 weeks after that, we're sending these text messages, reminding them of their restructured thoughts that are infused with hopefully self-compassion as a way to model using cognitive restructuring. So that's what we're doing. And we're able to monitor the dose effects, if you will, of this. And we're spending some time doing this right now. But that's the gist of how we're conceptualizing the parameterization in a very applied way. This is a visual of the text messaging. So they get daily text messages. How are you feeling? How are you feeling about yourself? From the start of the intervention strategy. For the proof of concept, they got something like this. everyone. For the pilot, everyone randomized to the intervention strategy, and now for the R01, everyone in the intervention strategy is getting this. During the course of those 5 sessions, they come up with these compassionate self-statements, as I mentioned, every session. So they have basically a library of usually at least 25 compassionate self-statements. And here are some examples. I'm more than just a junkie, or I deserve to take my medication. And then in the last session, the face-to-face therapy session, we have a worksheet where we say, okay, of all those compassionate self-statements, these restructured thoughts that you wrote, which do you think would be most helpful when you're feeling each of the response options for how you're feeling about yourself? And that's intended to be a way to extend the impact of the intervention, so remind them of the content of the intervention through those ideas, but also model using compassionate or cognitive restructuring to engage in what you might consider like emotional regulation. Yeah. So this is a flow chart of the pilot. So this was the K that is now completed. I'm not going to spend too much time on this because I want to tell you about iStrive too and show you some of the data. This is the consort diagram for the pilot RCT. So we screened over 350 people. We completed baselines on 75. So these are all men who have sex with men living with HIV with a substance use disorder, which we assessed via a clinical interview at baseline, who were suboptimally engaged in HIV care. So for the pilot, it could be either a detectable viral load or a self-report of not attending, I think, a visit in the past 6 months or year, maybe it was. I think the guidelines changed during the course of this, or suboptimal adherence. We ended up randomizing 50. Here are the various reasons that folks were excluded. And I think notably, our follow-up rates were very high. And I'll just name that we have a pretty substantial presence in the community here in Boston. We recruit from places where people get their subsistence needs met. So we would have had a much higher loss to follow-up if we weren't where people were having lunch and dinner, I think. Like we saw a number of people who lost their phones, and we would supplement their phone plans. And I think we bought a few people phones when they were eating. So we would see people when they were eating. They'd say, hey, I missed you. You know, I left, I had to leave Boston, or I lost my phone. And then we'd go ahead and schedule a visit. We also were very flexible in where we did visit. So we would either bring people to us. This was conducted at Fenway Community Health Center, or we would go to them. So in both this trial and the iStrive that I'm going to tell you a little bit about, we could go to where they were comfortable as long as the staff was comfortable. So we went to some housing first initiatives that had like a case management office. We used spaces at Boston Living Center, which is a community based organization for which we collaborate with when people wanted that, if they were there for food or case management or something like that, et cetera. So we were very flexible in our delivery strategy as well. So this is the demographics of I guess the 75 who we baselined, just to give you a sense of who we enrolled in this trial or who we engaged with. The mean age was like 49. We had about 47%, close to 50% identify as white, 32% as Black or African American, about a quarter identified as Hispanic, over 90% reported public insurance, which here is mass health. So we've expanded Medicaid, much like California. And education was really pretty distributed, I would say. The lion's share, the majority reported identifying as gay, and over half reported annual income of less than 20,000. Stimulant use disorder was by far the most common. And again, this was a clinical interview. So we didn't have a lot of people who met criteria for opioid use disorder. Those who did was just the 3 who met criteria for severe opioid use disorder. We saw a number of people with cannabis use disorder. We saw a smattering of other use disorder. I would say this was substantially like GHB, but also some other drugs like benzos. And then we saw a decent number with alcohol use disorder as well, over half. Polysubstance use was the most common. Most people met criteria for more than one substance use disorder in the sample. So feasibility and acceptability were our primary outcome variables for this pilot trial. And of the 67 eligible individuals who completed baseline, 50 were randomized, so that's a 75%. And 45 completed the study, so we had 90% retention of those who were randomized. And 77% was the average text response. So we got a decent number of people responding to text and proportion of text responded to. We used the client satisfaction questionnaire for to measure acceptability in the pilot, on which ranged from 0, quite dissatisfied, to 3, very satisfied. In the intervention arm, we got a mean of 2.7, and the control arm 2.2. So in terms of like our intended primary outcome variables for our fully powered trial, we really didn't have enough people to look at this, but we did see like a signal, we might say, of a difference in terms of being not being virally detectable at the final follow-up point. We saw a significant difference in adherence, self-reported adherence in the past week, although again, it's a really small sample for looking at this. And we do see a difference in longest number of consecutive days without taking your medication, or period between medication pickup. So, you know, this was enough, I guess, to get the R01, which is underway now. In terms of some of our hypothesized potential mechanistic variables, again, really small sample. This is N of 50. We looked at this, so I guess this is baseline to final follow-up. We see a difference, a reduction in HIV-related internalized stigma in both the control and intervention group. We see a reduction in internalized substance use stigma only in the intervention group, which I think is potentially meaningful, or at least a signal of what might be happening here. We don't see reductions in internalized homonegativity, but I will say they're pretty low from the start at baseline, which really tracks with the qualitative data from the INSIGHT study that I mentioned earlier, that mixed method study I did when I first got to Boston, which really indicated that, especially for people living in the Boston metro area, they were really feeling like the homonegativity that they were picking up in the community was much less. I will say, there were some people who had a very different narrative, and they were not from Boston. They were from like outside of Boston and more rural communities, which I think is potentially meaningful, having grown up in a rural community. Meaningfully, we also see a significant reduction in avoidance coping, which to me was really important as we think about, like, might this be working? Might we see something? Might we want to take this to the next level? And we did. We saw a reduction in the intervention group for avoidance coping, but not in the control condition. And just something that I noticed, it's really small, tiny numbers, but we did see this in the proof of concept, the tiny proof of concept work in San Francisco too. We saw a reduction in the severity of substance use. So this isn't a substance use intervention, really, I think importantly. We're not trying to get people to stop using. In fact, we say that explicitly at the beginning. This is a harm reduction intervention. We're trying to help people who are using in other ways with their kind of mental health and their like self-care behaviors, but we did see a reduction in people who met criteria for severe substance use disorders. And we saw that again in the proof of concept work as well. So we're looking at that more granularly in the R01. And the R01 is underway, as I mentioned, so I don't have any data to share with you, but we expanded it. We're doing it in Massachusetts and Southern Florida right now until it's terminated. It hasn't been yet. It's a hybrid type 1 design. So we're using the REAIM framework to assess facilitators and barriers. We're doing some preliminary cost. This was all designed, you might remember, to be scalable, to augment existing care at relatively low cost. So that's important, I think, to do the hybrid trial. We haven't formally included resource navigation. We ended up informally including it. We worked with a lot of folks enrolled in the pilot trial who had unmet subsistence needs. And I didn't mention, but in all of my studies, including these two, we have really robust resource guides that we update almost monthly. Actually, they're like 30 pages. They have content related to mental health care and substance use treatment, but also food pantries, housing support, immigration resources. Kind of, we learn about it, we add it. And this year, I'm proud to say, have added a convention to indicate what we know to be kind of LGBT friendly, especially for our Florida resource guide. That's very important as we're thinking about and that is subjective, but we've done some good work with our CABs to identify those organizations to try to help people in the best way we can, given that there's so many competing needs. We've added a time-matched asynchronous control condition, which I'm happy to speak to later if anyone's interested, but it's basically information about local resources. So we have video content that's matched 5 hours of video content about resources in Southern Florida and then resources in Boston, Massachusetts. And we're doing it in English and Spanish, which has been a lot of work, but I'm really happy to be doing that. Okay, so keeping an eye on the time, I'm just going to tell you kind of briefly about the iStrive study, which happened concurrently. As I mentioned at the beginning, around the time during the K, while we were doing data collection, we had an outbreak in Boston and Massachusetts more broadly among people who inject drugs, an HIV outbreak. And through collaborations with the Department of Public Health and various meetings that I was attending and frankly recruiting at, I had conversations about the ramifications of stigma, particularly for people who use drugs, and that it was a barrier for engaging in medical care. So I met with them, and well, let me say, there was also some evidence to indicate that people who were injecting drugs were intermittently virally detectable because of sort of intermittent engagement in management of their HIV. And there's some data from the Department of Health. We were seeing that there was a high number of people living with HIV who reported acquiring HIV, or who the Department of Public Health thought acquired HIV through injection drug use, who were detectable at some point in time, or not virally suppressed rather. So based on this work and my collaborations with community partners in the area, we wrote this grant. And it was funded ultimately. It took some time to get funded, but it was to develop an evidence-informed stigma-focused therapy to be paired with incentivized virtual directly observed therapy for people who inject drugs, who we later expanded to who use opioid and stimulants, really because of a very successful PIPE campaign in the Boston area. But this was designed for people who inject drugs, who have been virally unsuppressed in the past year. So the project had a few components. The first was to collect additional evidence, do that kind of qualitative data acquisition component where we asked people, what do you need? What do you think is needed from people who might benefit from such an intervention, as well as folks who serve that population. This one involved some formal meetings with Department of Public Health colleagues who may be in a position to fund such an intervention should it be deemed successful. And then we produced the intervention, and then we are finishing up data collection on this pilot RCT now. So I don't have data to show you, but I can speak to the parameterization of flexibility, which is why I included this. So we conducted 20 semi-structured interviews with people who inject drugs and other key stakeholders who ranged from infectious disease physicians, nurse practitioners, harm reductionists, community health workers, et cetera. And then I had 3 discussions with Massachusetts public health officials in relation to what they would fund in the future and what that could look like from a costing and support perspective. And then we did thematic analysis to identify critical components to develop consensus regarding the need for psychobehavioral interventions. I should say these were done in an iterative fashion, the interviews and then and the meetings with the DPH. And then design strategies for enabling engagement. So a key outcome was the need for thinking about context and making it as flexible as humanly possible. And the context really, in a nutshell, I would say was unmet subsistence needs, unsurprisingly, but also stigma. We heard this over and over again, for example, from an addiction medicine physician. I think it just captured the major sentiment, which is the instability in their lives is big and small ways, and makes it really hard to stay continuously in touch with folks. And the frequency with which the phone numbers and email addresses and other stuffs change is pretty surprising. So we spent a lot of time thinking about this and other related components or barriers to really doing psychotherapy or psychobehavioral healthcare with this patient population. There are lots of other quotes that I'm not going to share for the sake of time. But additionally, we heard a lot about the need for thinking about flexibility, the content, the duration, the delivery method, the location, the scheduling, and thinking about how we can really meet people where they're at. I know a lot of us talk about that, but how can we do that operationally for people who are often moving about and having different needs at different times? So and just to capture some of the sentiments that were shared, for something like this to be successful, it can't be the generic formula. This is what we're going to do for everybody. I think that is essential, allowing for rescheduling and drop in. And this person went on and on to say what else needed to be flexible. And then we started to offer ideas as we went. So this was done iteratively. We would kind of go back to the drawing board after we did a set of interviews and think about what else we could do. So we decided we were going to offer phones. We're going to pay for phone plans. We thought about how many times we were going to replace phones. And we got kind of corroboration of that from some of these interviews. Someone appreciated the fact that we were paying for phones, but that really was an indicator of some of the other conversations we had. So we ended up producing an intervention. Well, actually, before I do that, I have the qualitative conclusions. So I just gave you kind of a snapshot. I cut apart a different presentation that was more comprehensive about those qual interviews. But the qual interviews that we did really suggested that interventions could be used to mitigate the negative consequences of stigma, and that we could potentially do that for this patient population. However, for interventions to be effective, they must acknowledge the unmet needs and instability common among this population, and that we need to do something about it. We need to try to really meet people where they are and give them the tools they need to work with us, because the reality, I think, that was conveyed is that this is not necessarily going to meet their top priority. People need to get food and housing and other things, at least a bed for the night, in order to think about engaging in a psychotherapy session. And then the sentiment that was also conveyed, I would say repeatedly, and that we heard loud and clear, is interventions must be flexibly delivered, meeting people where they are both physically and cognitively, in terms of duration, location, content, etc. So what we produced is what we call the I-Strive intervention. It looked a lot like the Matter intervention with some notable differences. We still iteratively refine attainable self-care goals to really hone self-efficacy, which it can be a very empowering skill. We engage in metacognitive awareness of emotions and cognitions, which we hear people really like in relation to their drug use and thinking about how to get to where they want to go. We hear a lot in the study about being in kind of survival mode, and it can be really hard to be planful in any way beyond just keeping yourself safe when you're in that headspace. And some of the skills that we talk about, like even the mindful self-compassion, have been pretty well received by this group in terms of like, oh my gosh, I haven't really paused for a moment. And that can be useful. And the compassionate cognitive restructuring is very similar to Matter. And then we added assertive communication strategies. One thing we heard really loud and clear, especially from the people who might benefit from such an intervention, was that they felt like they felt unheard, especially in medical contexts. Like either they had to be really passive or really aggressive and that it was really hard as they were feeling very stigmatized when they went into like an ED or something. So we borrowed from dialectical behavioral therapy, or DBT, to do some assertive communication strategies to help equip people with the skills that might help them be more heard in some of these contexts. And we have like very applied examples, like going to a medical appointment and how to do that. So this is what the study looked like in a nutshell, cognizant of the time. Everyone has 3 months basically to engage in compensated directly observed therapy through an app on a phone. So we give everyone smartphones, we pay for their minutes, their data plans, everyone gets paid to take their meds every day. And then half the folks also get the psychobehavioral therapy, which we deliver truly as flexibly as humanly possible. We will go to them, and we just have to be familiar with the location to go to them. So I think I mentioned at the beginning, we've been to like Housing First initiatives here in Boston that have a case management office. We'll do it there. We have a lot of context around the city. We'll do it in community-based organizations for which basic needs are provided. We can do it in different hospital contexts as long as we can get a private room. We've had some folks who really insist on doing it in the park or something like that. And sometimes we'll even come up with like coded language such that we're not breaching any confidentiality, but if that's where people feel safe. We really, this study is aimed at trying to see what's possible, and see if we can get people this kind of psychotherapy. And ultimately the hypothesis, should we go on to get a fully powered trial funded, would be to see if when we take away the directly observed therapy, if those who also got psychotherapy have a longer lasting impact. Really, the question is if we can use the incentivized DOT as scaffolding, much like you would an antidepressant medication, concurrently with psychotherapy, to see if you take away the antidepressant medication, if the underpinnings might be mitigated by the psychotherapy that someone was kind of facilitated or enabled to get with more support. Yeah, and there are tons of ways we were flexible. I'm happy to talk about any of them if anyone's interested, but we went to the extent of being able to vary the length of the session, which was really facilitated by those tiers of detail, really, from like the manualized intervention, which is really detailed, down to those like 3 colors, just to hit the 3 tenets. If someone is really having trouble engaging in a session. Let's see. So, yeah, I'm happy to talk about this if we have time or if anyone's interested. So in conclusion, I wanted to share a little bit about the way I've been thinking about parameterizing, like flexibly parameterizing evidence-based content, in order to really meet people where they're at, because we have a lot of knowledge in this field, I would say, but we don't have a lot of good adaptation strategies that really are free enough to truly be effective. Something I kind of struggled with is, how do we implement some of these like really rigorous, but somewhat rigid intervention strategies with patient populations that really, it just doesn't make sense for. And I think a lot of clinicians were doing this off the cuff, which was commendable. And I think that there's a way to do this systematically, such that we can really identify our parameters and then really offer evidence-based, parameterized, flexible intervention strategies, because I think people deserve that. So we have found, I would say to date, that evidence-based psychobehavioral interventions benefit from being collaboratively adapted with and for people with substance use disorders. I would say that these collaboratively adapted interventions can be feasible and acceptable for people with HIV and substance use disorders, especially those who have unmet subsistence needs. And I think that there is a way to balance flexible delivery with thoughtful parameterization to increase access, as I was saying, to evidence-informed psychobehavioral resources for people who have traditionally been underserved by these treatments, which we have a really rich history of, but we could do a better job, I think, of helping more people gain access to them. Okay, and this is just some of the people on the team. It's an amazing team. It's not me, it's all of us. If you're interested, look us up, the Behavioral Health Equity Program. There are a couple of recent additions who are not on here, but a massive shout out to our team. And all of the people who worked on this, various interventionists, mentors, staff, others, etc. And I finished. I have 2:59.
That was wonderful, Abby. Thank you so much.
Oh,
And
thank you.
I think I want to just like commend you in your really successful like pilot and looking forward to the outcome of the RO1. We're sending you